Hello, everybody, and welcome. I'm Brianna Horan, Vice President of Clinical Sales at Galaxy Diagnostics, and I'm excited to bring you today's webinar presented in partnership with Quicksilver Scientific and Transcriptions. One of the most difficult parts of working with tick-borne illness is that these patients rarely present in straightforward ways. They often come in with years of multi-system symptoms, evolving diagnoses, conflicting labs, and treatment histories that never fully resolve. As clinicians, we're left trying to answer a difficult question. Are we dealing with past exposure, ongoing immune dysregulation, active infection, or some combination of all three? That tension between clinical suspicion and diagnostic clarity is exactly what today's webinar is designed to explore. At Galaxy, we focus on helping clinicians think through gray zone cases where conventional testing doesn't fully explain what providers are seeing. Today's conversation covers clinical reasoning, how to approach complex tick-borne illness presentations, where direct detection fits into your decision making, and how providers design protocols when stealth pathogens are part of the picture. Before we begin, I want to recognize our partner, Quicksilver Scientific, and introduce Charlene Olson. Charlene is a Northeast team lead at Quicksilver, where she partners with healthcare practitioners to advance education in functional medicine, detoxification, advanced diagnostics, and longevity-focused care. With more than 18 years in health and wellness industry, she built a strong reputation for helping providers navigate complex clinical challenges and connecting them with practical tools that bridge emerging science and real-world patient care. Charlene, thank you and the Quicksilver team for partnering with us today.
Thanks, Brianna.
Now, I'm pleased to introduce today's speaker, Dr. Chris Turnpaugh. Dr. Turnpaugh is the founder and president of Turnpaugh Health and Wellness Center. With more than 25 years of clinical experience specializing in autoimmune disease, neurological disorders, thyroid conditions, and complex chronic illness. He is board certified in functional neurology with extensive training in functional medicine and widely recognized body of work integrating advanced diagnostics into real-world care. His approach is practical and case-driven, and today he'll walk us through the clinical framework he uses to think through difficult tick-borne illness cases, including where direct detection informs decision-making, how he interprets positive versus negative findings, and how treatment strategies evolve across different phases of illness. Dr. Turnpaugh, thank you for being here, and I'll turn it over to you.
Well, thanks for having me, and thanks for everybody joining. So I think what I'd like to do is, let's get through that's me, that's the people that we just introduced. So I want to get into some testing and then some application. If you're like me, we're in central Pennsylvania, our office, and we have 20 different clinicians in the office, and super challenging when you're looking at tick-borne disease as to the testing out there. We all know the previous testing is kind of substandard. We're working through this. We're trying to get better diagnostics and better understanding and kind of going through what is real, what is a previous exposure, what is polyreactivity, what looks like there might be something there. Are we looking for an excuse to treat because we think it's Lyme? Are we actually seeing that it is? So what do we know? What do we don't know? So hopefully we'll get into better understanding of what we're seeing. So we all know that tick-borne disease, it's been on the radar lately, even at HHS. We know that it exists. This is just CDC, over 500,000 new cases a year, 3 times increase in reported cases over the past 20 years, 300,000 plus cases of Bartonella. These are patients that have classically come in, been dismissed, or diagnosed with other things such as chronic fatigue, mast cell activation, fibromyalgia, dysautonomia, POTS, post-viral conditions, autoimmune conditions, and all of those fit. We have a little immune diagram later that hopefully we can understand how it all goes together. But like if you are a chronic tick-borne disease patient, you're also likely to have chronic fatigue or fibromyalgia symptoms. It can lead to post-infection autoimmune conditions, obviously post-viral syndromes, and all of those are going to shift your immune system towards the side of the immune system which drives mast cell activation. So I think it's relevant to all these. So all these patients are already in our practices. And when we're really digging into what is driving it, tick-borne disease may be at the root of it. So is it a matter of, is it kill the bug? Is it only kill the bug? And why this conundrum falls short? I must digress here because I had a patient who was on 26 years worth of antibiotics and killing agents. And they came to our office and asked for, can I just get on more antibiotics? And I'm like, well, if you didn't kill it in 26 years, you're not going to kill it in 27. So hopefully we'll dive into how we can solve that problem. So what serology can and cannot tell you? So if you have an antibody response to a prior exposure, that means you're going to see the positive antibody in your on your testing. So these are your Western blots or some of your other tests that you see with an antibody exposure. This tells us that the immune system remembers seeing that pathogen. So when you have an exposure, you're going to have a B cell form and it's going to form a clone army, and we're going to see that. But you always have this, these are my antibodies. You're always going to have that memory B cell, and that's never going to go away. It may go up and down, but those antibodies can be there even when the infection is not there. So seeing a positive antibody doesn't tell us whether it's there. And we get into a little bit of a dicey situation with our, sometimes I'll call them the nemesis, the Infectious Disease Society of America, IDSA or association. So infectious disease is always going to say, well, so what if they have a positive IgG? It just means they have a previous exposure. On the other hand, if you have that and they were never treated, it probably is an ongoing exposure. So there is some validity to that, but it's just a snapshot of how your immune system has adapted. So what we really want to know is, the pathogen still there? Is it currently present? Are you currently infected with this? Is the organism driving the symptom? And should you go into a kill protocol? That's really the difference that we want to see. And if you run a test over and over and over again, say you run a test every 3 to 6 months and you're looking for antibodies, you're going to see the antibodies positive, most likely that you saw before. So what would really be nice is if we could detect that there's actually the pathogen present, right? Wouldn't that be beautiful? If we could say, not, I know that it's there. I know that I know that I know that it's there. And do we have a way that we can, when I say dig our heels in and talk to any other professional in the field, such as infectious disease, and say, nope, I captured the actual bug. I saw that it was there. I'm not looking for the reflection that it was there before, which would be an antibody test. I don't see an IgG positive, which tells me that there was something there before. And I'll digress a little bit. Well, I saw IgM, which means it's active. Remember that IgM antibodies are extremely well known to be polyreactive. So you can have an IgM positive. It doesn't necessarily mean that the antigen is there if the immune system is dysregulated to begin with. You can have an overactive immune system and have false positive IgMs. So if we follow the yellow brick road, you get your IgMs early, then your IgGs will stay present for long periods of time. But an IgM that comes and goes and comes and goes, some people will say that's the bug coming out and going back in and the bug coming out, or it's changing its outer shell protein, so it's a new antigen, so it formed IgMs. That's great in theory, and some of it may be true, but it also may be true that the immune system is dysregulated and we're getting these false IgMs. You see some of these tests where they're IgM positive to 40 things. Are they really that recently infected with 40 bugs? The possibility exists, but a better explanation is they're just polyreactive. They're reacting to everything. So we want to see if we can actually detect the bug itself or presence of the bug itself. And that has been frustrating for me for a long period of time. So I'm going to give you my version of how I got introduced to this. So there's a urine antigen test that Galaxy does. And the only way to have antigen shedding is if the bug is there. So the Lyme urine antigen test that you capture the urine, the antigen is being shed by the bug, and then they collect it in the urine and it's there. Well, you're not going to have antigen. Now, antigen, right? Antigens are antibody generators. So if the antigen is there, it means there's actual presence of the bug. You have the bug there. And then we're looking at digital PCR, which digital PCR, the PCR is actually looking for the actual bug that they replicate and amplify and see that it's there. So a positive PCR, you're not going to get a positive PCR unless the bug is there. So those are two of the direct detects from Galaxy. We'll talk a little bit more about those. And then on the right, you'll see they do have their own IFA antibody testing. Why I like it is it looks at all four different BART species, and they actually use the pathogen pieces, the actual pathogen pieces, not recombinant antigens, which are kind of made and they're not the exact bug. So they'll actually use the actual piece of the bug to see that it's there. So it's pretty sensitive. So if you can see an antibody, I mean, if you can see an antigen there, you know the bug is there. If you capture it in a PCR test, you know the bug is there. This is directly detecting the bug. This is not looking at, was the bug there before? Is this a false positive from a previous exposure or polyreactivity from another bug? This is saying, I know that the bug is there. If the two on the left are positive, you know for a fact you are dealing with the presence of a bug. Now, what's the difference? Because the first time they came to me, I'm like, PCR is garbage because you never see a PCR. I mean, those of us that have been doing this for 30 years were like, PCR testing almost never captures it. And it was frustrating because would have been nice if we were able to capture a live presence of the bug through PCR testing, but they were never positive. Very rarely were they positive. Occasionally you'd catch a Babesia positive because it was bloodborne, and so you could catch it in the blood, but it was really hard to capture it. So I had to be educated on this digital PCR where they take it and they drop it. It's essentially like 27,000 or 26,000 little droplets. They check each droplet for the presence of the bug. So the analogy is if you're looking for a needle in a haystack, if you separated that haystack into 26,000 individual little haystacks, it would be much easier to find that needle in that haystack. It was a resistance that I had to get beyond because through experience in patient interaction and testing, the PCR almost never came back positive. So as soon as they said, we have a great PCR test, I'm like, I'm out. I'm out because PCR testing is not going to capture this, doesn't live in the blood. It's not there very frequently, very hard to find. So very different. And it really revolutionized and changed. And as we'll go through specifically one of the cases, how it really changed our ability to detect, not just suspect that something was there. So I also get this question a lot. Well, I had a positive fish. I had a positive fish, so I know that it's there because the fish I saw in the immunofluorescence, I saw the bug. Well, when you talk to people who spend their lives, these PhD researchers on, and you ask them the question about, hey, I'm getting all these positive fish and I'm not getting any PCRs. They're like, well, that's not possible. That doesn't make any sense. Because for you to have a positive fish, that would happen in high abundance of the bug. So if you can capture it on a single slide and see it glow, there's enough presence there that you should be capturing any PCR testing. And again, oh, I saw a positive fish through this lab, but the PCR was negative. It doesn't make any sense. Because you should have enough abundance in the blood to not only see a positive fish, but if you have a fish, it should be confirmed by a positive PCR. And I wasn't seeing that correlation. So what we found is some of these things that glow as a positive fish were DNA fragments or maybe other pieces that kind of looked like the bug, but it wasn't the actual bug. And we know this because when you go into the science that PCR testing should confirm a fish test. If PCR testing is negative and fish is positive, you have to wonder how they could find it on a slide, but they couldn't amplify it when they took the blood out and tried to amplify it. So the question is the fish a false positive? And there we have a question of the specificity. Did we flag the pathogen, or did the test flag a pathogen that isn't there? Is it a DNA fragment that looked enough like the pathogen that it like it was glowing on the fish test? So just keep in mind that if you have a positive fish and you have a negative PCR, that's contradictory. You should almost always have a positive PCR even before you have a positive fish. And that's not even with the ultra sensitive, the digital PCR. That's just with regular PCR. Uh, so it was really contradictory when you see a fish test positive, and we would rely on that. Like, oh, we saw a fish, it's there, it's present. Where the heck is the positive PCR? It should really be there. So I would encourage everybody to ask those questions as well. If you're getting a fish, why aren't you getting a positive PCR? And if you're getting a fish, you certainly should get a positive digital PCR. And if you don't, you got to wonder what you're seeing glow on that immunofluorescent slide. So a couple cases, they highlighted two cases for me. So case one, interesting fellow, came in to see me. He proudly told me I was the 54th clinician he had seen. He was miserable, and he did have severe food sensitivities. He had major gut surgery. He was actually at Temple with a very well-known GI surgeon. They didn't know what to do for him. He was in so much pain. They opened him up and they actually burned all the nerves that attach to the GI system just to get him out of pain. He came out of surgery, his gut pain was better for about 4 days, and then the nerves started going back and it all came back. He has significant environmental reactivity. He had seen, like I said, I was his 54th provider, and I'd been seeing for a period of years. Now, we cleaned up his gut, we healed his gut, we treated him for many different things. He had mast cell activation and he was doing better. And as he says, we gave him his life back, but the final piece was never there. He still suffered a little bit. And so after this testing became available, I said, well, we could revisit. And he lives in Maryland and he's a hunter and he's out all the time and he's an outdoorsman. And he's super confident and super wealthy. So he's one of those guys that like, just fix me, just fix me. So I was like, well, we could do this test, even though we've tested you in the past for tick-borne disease. I said, but we can certainly test you. So here we did this test, and we were able to capture a positive Babesia on direct detect. I've tested him in the past. I thought we put the subject to bed. He comes back positive on the digital PCR for Babesia, which means it was there. It was actually there. He was so sensitive. He owns several properties. One of his properties was next to a turkey farm, and he's so reactive to soy that when the turkeys ate soy and they took the turkey feces out, he would be curled up in a ball in pain just from the reactivity of the soy exposure from the turkey poop. Yeah, again, he owns several properties, but he would lay on the floor of his barn and just curl up in a ball. They had him on a morphine drip at times just from the pain. So although he was doing better because, yes, we took some of the food out, we healed his gut up, we did some different things, he was still suffering. So we find the Babesia, we treat the Babesia, and he says, now you're my superhero because I feel so much better. So it was a great eye-opening experience to me. I had been seeing this patient for, gosh, I don't know, 15 years, again, doing better, but I was kind of at my wit's end. He had a lot of symptoms before, like a lot of the things that go along with immune dysregulation. We kept trying to fix those. But when we treated him for his Babesia, his life completely and dramatically changed. So these are some of the things we did with him. And I want to get into why it might be a little bit different using the liposomal forms of these ingredients. So, as many of you that are familiar with Quicksilver, it's a nano emulsion. So we put these ingredients in this really, really tiny fat ball so that when you take it, it actually can get into your system. So you take it, you hold it in your mouth for a minute, it'll absorb through the cheek lining. When it goes through the cheek lining, it's able to get into the cells. Since it's nanoemulsion and it's liposomal, it has a great opportunity to penetrate biofilms. It has a great opportunity to cross the blood-brain barrier. It has a great opportunity to get where the bug is and kill the bug. So this bioavailability really enhances the active herbal to get to the source that it needs to be. So some of the things, there's 3 phases and you'll get this, but you wanna prepare the terrain. So you wanna get the bile flowing where the bile flows, the toxins go. So you can use things like liver sauce and bitter X. I love bitter X. I just did it a second ago, but I keep bitter X. Well, you can't say it. I keep bitter X on my desk. It's a bitters. Every time I talk about it, put 2 pumps in my mouth. So I can't not do that. That just helps the bile flow. The liver sauce is also helpful for detox. We all know that glutathione is the master antioxidant. I call it the body's bodyguard. Really helps with oxidative stress and it's a master antioxidant. Really calms down any Herx type reaction, Herxheimer reactions. Want to bind the toxins and get them out of the system. So the ultra binder capsules, a fairly new product for Quicksilver, but it's the BPC plus KPV. So the BPC will help the tissue repair, but the KPV has been very valuable at reducing that inflammatory response going on in the body. Also, downregulates a lot of that Herxheimer reaction with the KPV. I mean, there's a lot of things that we're not going to go into, but certainly they have to have vitamin D. If their vitamin D isn't up to speed, and I would say if your vitamin D isn't above 50, if you're compromised, I'd say above 80. So it turns on 2000 genes for gene transcription. If you don't have the proper terrain and you can't get this stuff out of your body, even killing it off, they're going to feel really crappy. So this is just prepare the terrain, prep the body for the kill protocol. Kill protocol, you're going to cover so much just with doing the liposomal cryptolepis, the cryptocomax, and the cat's claw VMAX. So they're targeted ingredients that cover all 3 of the bugs. Your Cryptocomax has a little bit of the artemisian in it, and it's a killing agent that has been shown to be effective for the 3 Bs, the Borrelia, the Bartonella, and the Babesia. So it covers all the 3. The cat's claw is also very helpful at killing. Cat's claw has a peptide in it called AC11, which also supports your mitochondria, which are usually beat up when these people get all these antibiotics that they've been taking. Ergothioneine, 2 antioxidants, has a little bit of the glutathione in it with the ergothioneine. And then you can use something like kidney care or something that supports the membranes. Also fairly new is the transcriptions, which is also part of this. They have a methylene blue. Now you see this little box down at the bottom. My only knock is there's only 4 in that little box, which drives me crazy. But inside the box is 4 little tablets, and they are 50 milligram squares. They're called troches. I have my patients swallow them because it's very well absorbed. You can put it in the mouth and they can use it as a troche, but their entire mouth will turn blue. So, understanding the nuance of methylene blue, when you get above 50 milligrams, it's a pro-oxidant, so it actually helps to kill the bug. And when you use it in low doses, it is antioxidant, supports mitochondrial function. So if you're using it as part of your kill protocol, you want to do the high dose. If you're using it as support, you may want to do a lower dose. And then recovery. Recovery again, we'll see the BPC with KPV to help repair the tissues, the thymolin and zinc complex, which will help repair everything. The NAD platinum is for mitochondrial repair. The one has CoQ10 and PQQ in it. So again, we're supporting the energy and the mitochondrial aspects, which almost always take a hit when you're chronically ill. So then we go into case 2, which is fascinating to me, case 2. So both of these cases were fascinating, almost cases I wouldn't believe if I wasn't the one taking care of them. I mean, who comes in and said, I've seen 54 doctors and had all the nerves in my stomach cut off, and I've been everywhere, and I had a morphine drip in the hospital. So the second guy, also been a patient for a long period of time. He came in to see me. He is here it is. He's a world-class athlete. He was ranked 8th in the world at one time in mountain biking. He's a mountain climber, ice climber. He's had climbs named after him because he was the first one to climb it, an extreme elite athlete. So in his prime, he was about 175 pounds. When he first came to see me, he was 112 pounds and looked emaciated. Had 13 separate positive autoantibody markers to self tissue. So, as he likes to say, he had 13 autoimmune diseases. He wears that proudly on his chest. I don't know if he had 13 autoimmune diseases, but he tested positive to 13 autoantibodies and he had the symptoms and tissue damage of about six of them. So, he was pretty messed up. It's very, very, very thick blood with polycythemia. Anyway, he did great over years, but he's an extreme person. He's not just an extreme athlete, he's an extreme person. So he decides he's going to disconnect from society, gets a camper, and lives in the woods all the time now. Gets up every day, 5:30, has his morning coffee, and then he goes for about a 15-mile intense bike ride, followed by paddleboarding for about 2 hours every day. That's kind of his morning. So he comes in to see me after he's, again, I won't say world class, but elite. And the whole office knows him, very gregarious, very outgoing, kind of comes in. He loves us because he went from basically desk door to really good, pops in all the time, brings the front desk treats all the time, super gregarious guy, comes in a walker, couldn't even hardly move. Comes in, he's swollen everywhere. He thinks he's dying again. Comes massive joint swelling, unable to walk. His wife's basically carrying him in. And he's out in the woods all the time, pulls ticks off of him all the time. I said, well, we're going to go ahead and treat you before we even get the test back because I'm positive that you have something. So we tested him. Ironically, he tested negative, but we started him on antimicrobials and antibiotics, but quickly went into immune regulation. So two different cases. This one, I think he is primed for an immune reactivation of dysregulation. It's a mouthful. He threw his immune system out of whack. So I don't know what he was exposed to. It could have been a spider bite for all I know, but he certainly had what appeared to be a positive tick-borne illness based on his symptoms. So we used clinical judgment. We jumped right in. We did the crypto Comax, the cat's claw VMAX, and we did antibiotics right away. We also did some things to improve his immune system. And, he thought he was going to be out for about, he's very positive. He says, I'll be back in 3 months. Everybody that knew him thought he was dying. So he's like, there's no way you're going to recover. Well, he had 95% improvement within 6 weeks. So very, very dramatic response with quick application of killing and immune regulation. So two different cases. One, I missed for a very long period of time because I didn't have the testing available. This one, I thought for sure. I thought he was going to test positive for everything, and he tested negative for everything. So, still use some clinical judgment to start treatment, had a good outcome. Just keep in mind his history. His history was he has memory B cells to 13 self tissue antigens. So, 13 possible ways to reactivate autoimmunity. So that brings us to this slide, which is a slide I kind of live by. And if you'll look here, you see my cursor. Can you see my cursor? Brianna, can you see? Okay. So when you get an infection, this side of the immune system kicks in. The Th1 side of the immune system will kick in, recruits the natural killer cells. So we have the innate immune system and the adaptive immune system killing things off. When this system gets depleted, we shift over to the Th2 side. So Th1 and Th2, it's like a seesaw with the regulatory cell right in the middle. So if Th1 is dominant, Th2 is low. What happens over time with chronic infections and chronic dysregulation is Th1 tends to go down, Th2 tends to go up. I don't have it on here, but when you're Th2 dominant, there's a little arrow I have on another picture, and it says mast cell degranulation and histamine response. So this is by definition, if you have mast cell patients, they're Th2 dominant. These are also the patients that have chronic UTIs, upper respiratory tract infections, asthma, allergies, that chronic inflammatory response. these Th2 and Th17 dominant situations lead to the autoimmune disease. So we can get an infection and not completely fight it off, deplete our Th1 side of the immune system, create a Th2 dominance, and allow a backdoor for Th17 to come in. And this can drive the autoimmune disease. So with patient one, a lot of gut issues, a lot of food allergies, a lot of dysregulation. So the gut here is constantly leading to an exposure, driving a Th2 response. That may have been precipitated by his longstanding babesia. So we want to also look at this and say, hey, you have symptoms of inflammation. So tissue inflammation and tissue breakdown. Is it Lyme? Is it tick-borne disease? Or was it Lyme and was it tick-borne disease? And you're just stuck in a state of Th2 dominance or Th17 dominance. And now you don't have the ability to fight anything off. So what we want to see is, can we confirm without a doubt that we have the pathogen positive? Patient comes in, meets all the clinical, it's a clinical diagnosis. And the reason it's a clinical diagnosis is because testing wasn't good. So if you're relying on the testing and the testing was poor, you couldn't rely on the testing for a positive. We're now getting our head above water with better testing to see these pathogens. So what we want to know is, do you have the pathogen present? Is it actually there? Can we confirm that the bug is there and we need to kill it? Or is the bug not there and we just have the immune system dysregulated? So, as I say, are we treating active pathogen or the ghost of pathogen past that we have to get past? So, it would be really nice, because if you're using, let's just jump into, say you're using antibiotics for what you suspect is a positive tick-borne disease, and because of symptoms or because of antibody testing. And so I'm going to keep hammering this with antibiotics. By definition, you're beating up the mitochondria. By definition, you're beating up the terrain. You're tearing down your microbiome. And if you continuously do that and the bug isn't there, you're actually making the host, meaning the human being, worse. And sometimes these antibiotics have anti-inflammatory properties. So patients will tell you, I only feel good when I'm on an antibiotic. Well, that's not because you're killing a bug, it's because you're having an anti-inflammatory effect. So it's great to be able to have testing that says it's really there or it's really not there, type of a thing. So if we get a positive test, we can confirm that it's positive. We can go ahead with a kill protocol. If we have a test, we suspect that it's there, the test is negative, we can shift over to a terrain and immune system focused protocol. And we can then support that balancing of the immune system and the barrier protection. And that, by the way, if you do that, you're still supporting the host, even if you have to switch back and say, well, now it's time to kill the bug. You have built up a better host. So one of our clinicians says the health of the host matters most. So you want to make sure that the person is as healthy as possible, even if they have to go through a kill protocol. You want them healthy through that kill protocol. So we want to get them healthy and keep them healthy. So I would say this is important. Coming back to this picture is important if they have an ongoing infection. So they still have an active infection, but it's been there for a while. We still want to support the Th1 side of the immune system because it's probably beat up so they can fight the infection. If they don't have an infection and they're just stuck in a Th1 insufficient state, or think of it as a Th2 dominant state, they're going to have the same symptoms. This is analogous to, because it's been popular, long COVID doesn't mean you have to kill COVID more. It doesn't mean, oh, you have a long standing COVID infection. It's this same picture. In fact, I used this for PA Lyme. This same picture was, and I used it for COVID versus long COVID versus long Lyme, I'll call it, because I don't want to call it post-treatment Lyme syndrome anymore. But if you have long COVID, you wouldn't say, well, you need to use stronger antivirals to kill the COVID's not there anymore. And a lot of times that's what happens with tick-borne disease. The tick-borne disease may not be present. It may be, but it may not be, but they have the same type of symptoms. I had a patient once who had a bullseye rash on their deltoid, and they had Lyme disease, were treated, and whenever they ate gluten, the bullseye rash came back. Couldn't make up the story if I tried. So every time they ate gluten, they didn't need to go back on an antibiotic to kill Lyme. They just needed to realize they were stuck in an immune dysregulated state. My slide went backwards. So fix the terrain. You need to fix the terrain and repair whether you have the bug or don't have the bug. The kill protocol, you know you are standing on solid footing if you have actually directly detected the bug. The best way to directly detect the bug is if you have antigen present or you've actually captured it through a PCR. I mean, and those tests were not available a long time ago. And we relied on antibody testing, which was fair at best, or we relied on fish testing, which I had to be educated on, makes no sense if you have a negative PCR. So being able to directly detect this bug is an absolute game changer. So again, going over the recovery, in the recovery phase, the big difference here is if you're looking at that methylene blue, you want to use the low dose of the methylene blue, six and a quarter to 12.5 milligrams of the tro blue. This is low dose. This is going to support the mitochondrial recovery, mitochondrial health. Having the one which has CoQ10 and PQQ, you're going to support the mitochondrial health. Any of the phospholipids are going to repair the tissues, and the phosphocholine is the medium that's in all of their products. So you're going to get some phosphatidylcholine in all of their products to repair the membranes, repair what's going on. The thymulin zinc complex helps the immune system repair. So big difference between the treatment with methylene blue and the recovery from methylene blue is high doses is a kill protocol. Low doses is to support the mitochondria and recovery protocol. So acute Lyme, I'm glad they put this in here. So first you want to remove the tick, use a flat tweezer, pull, steady pull, and then send the tick to somewhere. Tick report, in PA, it's free. It's if you're a PA resident, it's ticklab.org. You can send this off. You can get it tested to see what's going on. Nice thing about this is if you're waiting for an antibody response, you have to wait 4 weeks at least to see if your antibodies show up. From day 1 to 3, you can actually do the Lyme urine antigen test from Galaxy because that bug is going to start shedding its antigen, and you'll be able to see that right away. So you can directly see if Lyme disease is there. What I do is I'll use the Cryptocomax, and most of my patients have it on their shelf if they're ever exposed to ticks. So I can't tell you how many patients they don't. It's kind in case of emergency break glass, they have the Cryptocomax. I have them do 2 doses a day for 2 days, and I have them also apply some right over the tick bite to get right on the source. Does it make a difference? I don't know, but I'm applying it right to the source. And I have never had a case develop Lyme disease once I initiated that right from the get-go. So 2 doses twice a day for 2 days. So 2, 2, and 2, and I also have them apply some right over the tick bite. So that's kind of my emergency, if you're bit. Also, if the tick had any of the bees, Borrelia, Bartonella, or Babesia, it's effective in all 3. So that's my in case of emergency. So your 2 main players in this are going to be your Cat's Claw VMAX and your Cryptocomax, super effective at all 3. And then if you're going to use methylene blue, if you're going to use it as a kill protocol, you're using the high dose and then drift them into low dose for recovery. So your takeaways are these patients are already in your office. And if they're chronic, you're not going to, you may see positive antibody testing, but you want to know if the bug is still there. The serology tells you it was there. It doesn't tell you that it is there. So a positive result with direct detection means you have confidence in treating it. And a negative result means you can apply clinical judgment to see what's going on, but it's not necessarily that you have to kill. You do have to go through repairing and balancing out the immune system. The immune system support and restoration of terrain should be part of every protocol, active bug or previous bug. The best window is the earliest window, and you can do these tests because when they're acute, you'll pick up the PCR, you'll pick up the antigen. So it doesn't matter if they're on an antibiotic or not on an antibiotic. It doesn't matter if they were recently bit or not recently bit. You'll be able to pick this stuff up through direct detection when the bug is present. I failed to mention that things like Bartonella, they cycle in and out of the bloodstream every 2 to 4 days. So the Galaxy triple draw, which is what I use, you'll actually draw 3 different samples in an 8-day period. So you're catching that Bartonella when it cycles out of the blood, because if it's hiding in the tissue and it doesn't come out to reproduce on the day you drew, then you're gonna miss it. Another reason. So also, they take the sample and they culture it and allow it to grow in a medium that amplifies the Bartonella, so you're able to put it in this, like, goo where it actually feeds and grows, and you're, like, feeding the bug so it grows for a period of time, and then they'll test it again. So, I mean, just a huge, colossal jump forward in testing, not just to see if something was there. We know these antibodies can be polyreactive or false negatives, but when you see the bug, you know that it's there. You can go in with guns ablazing to kill the bug. Don't forget the terrain. You always want to heal the terrain. So, and questions and answers, and that's how you get all the information.
Thanks, Dr. Turnpaugh. That was amazing information. I do want to mention that this is recorded. We are going to send the recording out to everyone along with the slides. Transcriptions is a separate company from Quicksilver. I am the rep for both Quicksilver and Transcriptions, but you can scan the QR code there, and you would need a separate account for to get the methylene blue with them. And the Galaxy information is in the top left corner. And then we'll open it up to questions.
Great. Thanks, Charlene. For those of you who have questions for any one of us, including Dr. Turnpaugh, please, by all means, at the bottom of your screen, go ahead and select the Q&A and type in your answer, your question.
Type in your answer too. That would be helpful.
And while you guys are thinking about your questions, the protocols that Dr. Turnpaugh has discussed today, we put that there. So if you want to take a screenshot uh, of the screen there, those QR codes, you will be able to download both protocols, the one offered with Quicksilver, the 3 different phases, and transcriptions as well.
And I
Dr.
know we went through everything quickly, so I kinda gave you a brief overview. Just know that there's better detection and better treatment, and you can ask both of the companies how what that means, so
Can
All
you
right. Oh, go
say
ahead.
what the patient is going to experience when they're going through the protocol? What are some of the ancillary tools that you use to help with the herxing? What are some of your tricks?
well, you can there's a bunch of tricks to use. So one, you can use things that downregulate histamine, like Histaid. You can use different things that are going to calm that histamine response down. You're going to rely more heavily on things like glutathione and ergothioneine. So the ergothioneine, you really make sure their vitamin D levels are healthy. You know, we talk about herxing so often, and we screen every patient that we see for tick-borne disease, and we see about 250 new patients a month. Now, we have a lot of clinicians. So, we don't see a lot of herxing. I mean, very rarely do we see herxing, and so people talk about it all the time. I tend to think we haven't done enough terrain repair before we do the kill situation. So, I mean, if somebody's vitamin D is 17 and their immune system is shot and their gut is all issued and they can't detox at all and their liver's stuck and they're not having any bile flow and you start them on a kill protocol, they're going to feel terrible. So I would and again, we do have patients herx, so I'm humble, but you're going to get far less herxing if you prepare the terrain for the battle that's coming.
Great point.
All right. So we have some questions coming into the chat. Does the blue color from the methylene blue go away on its own?
Oh, yeah, 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 like, it doesn't stain your teeth permanently, but I'll tell you, you will pee blue.
Yeah.
You will pee blue, you will pee blue. So it freaks people out. Let them know that their urine will turn blue. It's normal. It is a dye that's used in clothing too, but when you get it in your mouth, your teeth will turn blue, but it will go away. Yeah, it does go away on its own. You don't need like any special boric acid on your teeth or anything to get rid of it.
It's a good question. Okay, so for those that ask where you get the Cryptocomax from, the Cryptocomax is from Quicksilver Scientific. You can go ahead and scan that QR code there to open an account. Charlene would be more than happy to help you out with that. We have another question. What role does long COVID play with Lyme diagnosis and treatment? Does a COVID vaxxed patient differ from a non COVID vaxxed patient's diagnosis and treatment? A little bit of a twofold question. The first part, what role does long COVID play with a Lyme diagnosis and treatment?
Well, I would simply say, if I may be so bold as to go back to here, if you have long COVID, you most likely were primed for that because you were Th2 dominant or Th17 dominant. You didn't have a regulatory T cell robustness and you didn't have a Th1 response. Now, if you had Lyme, and you didn't have your terrain repaired, you were primed for anything, including long COVID or an autoimmune disease or cancer, right? So these are the two things that people are talking about with COVID and with vaccine injuries. We're seeing autoimmune diseases and cancer amongst everything else. These are probably people that are already Th2 or Th17 dominant patients prior to infection or vaccine. The so I would say if you had Lyme and you didn't have your terrain fixed, you're more likely to have long COVID or a negative symptom from getting anything. And part two was what was that about the vaccine?
Does a COVID vax patient differ from a non COVID vax patient's diagnosis and treatment?
Well, what we know, I'll try and keep this neutral. What we know is that when we had the COVID vaccine, especially with the mRNA, we amplified that spike protein through the roof, greater than the effect that you would get from a natural immunity. So when you got COVID, yes, you had this. When you got the vaccine, it really amplified that exposure to the spike protein. So if you had any kind of pre-existing dysregulation, you had a greater antigen exposure from the vaccine than you did from actual contracting COVID, which gave you, if you were out of balance at all, gave you a greater probability to tilt you this way. Oop.
A third part to that question, patients with confirmed mycotoxin toxicity.
Yeah, mycotoxin toxicity. So if you have mycotoxin toxicity, the great question, it's Lyme, it's mold, it's mold, it's Lyme. It's immune dysregulation in both of them, right? So if you have mycotoxin exposure, you have dysregulated TGF beta. So if you talk to like Richie Shoemaker, this is his marker. Yeah. So mycotoxin exposure is in, and this is classic. I get on my high horse a little bit. Why do three people live in a house, but one person's deathly ill from mycotoxins? They're all exposed to the same mycotoxin. It's, yes, genetic susceptibility in your HLA-DQ, genetic susceptibility. It's also immune dysregulation and a chronic state of inflammation. So anybody who has mycotoxin exposure, some people have tick-borne disease that they're keeping at bay. They get a mycotoxin exposure and they go off the rails. Some people have mycotoxin exposure in the background and they're just treading water. They get a tick-borne disease and they go off the rails. The common denominator in both of those is immune dysregulation. So you still have to fix the terrain in both of them. Different protocols going forward to deal with mycotoxin than tick-borne disease, but recognize this immune system is ubiquitous in all of us, whether you have mycotoxin or tick-borne disease.
And that would be the phase 3 in our protocols to help rebuild that terrain and support the immune system.
I would actually say 1 and 3, right? So 1 and 3,
Right.
yeah.
Yeah.
Right.
Do you want to take it
I
away?
have one question. We have a question regarding, can Lyme or Borrelia burgdorferi also be from a spider bite?
Ooh, a spider bite. I would probably ask the researchers that. I know, I don't know that anything's impossible. I know it can come from a mosquito bite. I know it, but so mosquito lives an average of 2 days and a tick lives an average of 2 years. So, I don't know the answer to that I would ask
I would
some.
say, I will definitely ask this question and we'll include this in the follow-up email that everybody will get. But Dr. Breitschwer has done some research and would say that most likely what's transmitted from the spider bites is Bartonella is more of a risk factor than Lyme, I would imagine. But I'm going to confirm that in our follow-up email.
Yeah, by the way, it's in ticks, but it's in like 67% of feral cats in North Carolina. So it comes from fleas. So Bart is underappreciated completely because Bartonella you can get from being scratched by a cat. You can get it from fleas. You can get it from so many different sources. So,
Yep. Lice, sandflies.
mhm,
It's a fun time on Bartonella.
yeah.
All right. We have one other question. I've heard that Galaxy is superior to detecting Bartonella, whereas Vibrant Wellness is superior for detection of Borrelia. Have you seen this discrepancy? Maybe you could talk to the difference of the antigen versus serology.
Yeah, I would say that, well, hands down, I would how do I answer this? Hands down, I think that the IFA or the antibody testing from Galaxy for Bartonella is superior. It's more specific. They're using the actual bug. If you wanna know, well, and to be fair, Galaxy doesn't do the indirect testing for Lyme. They only do it for Bartonella because they're just better at it. If you wanna know what's better at direct detect, there's no question. So if you wanna know who's better at indirect testing for Lyme, well, Galaxy doesn't do that, so I can't answer that. But if you wanna direct detect, if you wanna know that a bug is there, you're not gonna get a better test than the Lyme urine antigen test from Galaxy. So if you wanna see if something's there, you want an excuse to treat, and if you want a reason, if you want a positive antibody test, you can go to a lab like Vibrant. If you wanna know the bug is there and you're actually treating something that you know is positive, you're probably gonna wanna go with Galaxy.
Okay, thank you. Have you used systemic water soluble zeolites successfully for treatment of all mycotoxin and Lyme disease?
Well, I'll just leave it. Zeolite's a nice binder. Zeolite is a nice puller and binder. I think it could be part of an equation. That's really kinda gets into that's just one piece of a treatment for it, but I don't think it's an ineffective way to bind some things.
Our Ultra binder is very universal. It has a lot of ingredients for that purpose, so that no matter what is being thrown at it, it's a good chance it's binding it up.
We have a question of will the slides be available? Yes, the slides along with the recording and the Q&A will be sent out as soon as the recording has been edited. One more question we have is what about a negative dPCR for Bartonella, but positive Bartonella IFA in the same person, same sample?
Mhm. So 2 things could be possible there, right? It's a great question, by the way. That's a phenomenal question. So, uh, one, if we have a positive IFA, we know at the very least there was a previous exposure to Bartonella, right? Because especially through Galaxy, because they're so specific and they're using the actual they're not using recombinant pieces, they're using the actual bug. So 2 things can be possible. If you have a robust enough immune system that when the bug comes out into the blood, you can attack it and kill it before it can be detected through the digital PCR. So you may still have a positive if you have a, a powerful enough immune system to attack it when it comes out into the bloodstream. And then I'd also ask what levels were your IFAs at? Were they at greater than 1 to 164 or yeah, 128. If greater than 128, I'm sorry, I had to do the math in my head. Greater than 1 to 128 or 128 or greater, I would call that very likely a positive, especially if they're coming back and they've never been treated for BART. So if you have a positive that's high and they've never been treated for BART, I would have a very strong suspicion that there's still BART present. On the other hand, if they've been treated for BART and the BART has seemed to resolve or the BART has been treated effectively, it may be a previous exposure still. So you might still have a previous exposure. So that's a little bit of clinical judgment because if you have the positive antibody test and showing robust and you have a negative PCR, maybe that antibody robustness is telling you that when the bug comes out into the bloodstream, your immune system is attacking it and killing it, or maybe it's just a previous exposure. Brianna, I'd let you answer that as well.
Yeah, what I would add to that is in a lot of the published research that Dr. Breitschwart has done, really the bigger question is if you have a patient with a high risk of exposure to Bartonella, they are presenting with symptoms, and if you're running serology only, especially even through Galaxy, right, with the IFA, if that result is negative, we have seen that patients with a negative IFA tend to be more likely be positive on the digital PCR because, like Dr. Turnpaugh is saying, the immune system is not responding to dampen the DNA presence of the bug. So providers will often ask, can I start with the IFA? You can. Keep in mind, strong clinical suspicion, high risk of exposure, symptoms are present, and if the IFA is negative, that really is the patient that needs that triple draw DPCR because those are the most likely to be positive. We call it the seesaw effect, right? Strong IFA, less likely for the DNA to be present when you have a strong immune response, but a weak immune response, more likely that the pathogen is able to be detected. So best clinical picture would be to do both at the same time.
And I would say if there's a strong clinical history and they have any psychiatric symptoms, I I'll tell you that they're BART until proven otherwise.
Yeah, neuropsychiatric is definitely what BART's most known for, but think also ocular. I could present with visual issues as well, visual snow, blindness in the periphery, a blurry vision that comes and goes. Can also be presented cardiovascularly. Bartonella cholerae specifically, more recently discovered species from cats likes the heart tissue. And then also, most commonly, people are familiar with the Bartonella striae, right? You think it might be stretch marks, but it doesn't follow the dermal planes, or typically they don't blanch. If a patient has stretch marks, that can also be indicative of a Bartonella infection as well.
Foot and heel pain.
Yeah, yeah. Uh, Charlene, Dr. Turnpaugh, any last words as we wrap up tonight's webinar?
Oh,
This is great information. We do have one question with Galaxy testing being available in New York that just came up,
Oh, great question. We're working on it.
like all the other labs.
But if you have specific questions regarding New York, by all means, the slide before has my email. Feel free and we can have a conversation. Thank you, everybody. Thank you so much, Dr. Turnpaugh. Thank you, Charlene,
thank you.
Transcriptions, Quicksilver. Really appreciate the collaboration here tonight. Everyone have a wonderful evening. Take care.
Thank